case. We need some music for this, for Sherlock Holmes. We have Sherlock Holmes Watson hats here in the studio. We also have hats for blokes, and we have a nice, very nice Sherlock hat, which is a deer slayer. We'd like to go ahead and start the presentation here. Good morning, Shannon Slattery. Glad you could come this morning.
Thank
Our
you.
mystery case is, we shall begin, a 54-year-old female nursing assistant who presented in the outpatient setting way back in November 2013 without any complaints. She had a right bundle branch block and was referred because of an abnormal EKG. Now, that had been seen before in August of 2013. That's as far back as we go on EKGs, so we don't know when that popped up. But she had no symptoms at all. She did have a history of hypertension, hyperlipidemia, left breast cancer, status post left lumpectomy, and left breast irradiation 3 years ago. Also a history of some depression. We colorize this in blue because as we go on, we'll give you clues once in a while and highlight the clues, but in the future we're not going to give you clues. But we want you to get used to this this style, the Socratic method of question and answer. So she had left breast lumpectomy, right breast reduction. She smoked 2 packs of cigarette a day for 36 years. No alcohol, sedentary lifestyle, worked as a nursing assistant, so she would lift patients and move patients around. So she was pretty active. Her father had hypertension, high blood pressure, and had sudden death at age 74. Her medications were lisinopril, HCTZ, 10/12.5, Plendil 5 milligrams, Crestor 20 milligrams, Famara 2.5 milligrams daily, Wellbutrin, Claritin without the D, calcium, and Motrin PRN. She had no known drug allergies. Physical examination was normal, unremarkable. This is her EKG. Pooh, would you care to comment on her EKG?
Sure. It's sinus. As you said, that's right bundle morphology, RSR. P waves look normal size. They don't look big to kind of elucidate that there's right atrial enlargement too. Pretty much otherwise, the R wave progression is fine too. It's low voltage for sure. Less than 5 in the limb leads and 10 in precordial, so it's low voltage. But,
okay, it looks like her PR may be a little bit long there. Not sure how.
First degree we blocked, right. And axis looks a little bit leftward, I would say.
Sometimes with right bundle, you have a little more T-wave inversion in V1, 2, and 3, but she doesn't have much there. But sometimes you see a discordant T-wave, and that can be normal. And even when doing stress tests, you can still do a stress test on a right bundle and see ST and T-wave changes.
Correct.
So what are your thoughts about the right bundle, Pooh?
Right bundle, broad differential, any right-sided heart pathology, either COPD, pulmonary hypertension, can be a marker of underlying CAD too. Some studies have shown. Right heart strain wasn't really fitting because there weren't any T-wave inversions usually that we see with right heart strain. Her voltages are pretty low too, so infiltration of like infiltrative cardiomyopathy is a possibility. She got radiation too.
And so sometimes coronary artery disease, where you have an infarct and get right bundle.
Right.
What to do next? There's a lady who basically has a right bundle and was sent by doctor to us cardiologist for us to elucidate something wrong with her. And so what would you like to do in the menu here?
Echo, and then followed by like some kind of ischemic workup. If echo shows any wall motion, then we follow up.
Here's your echo report. Do we have the echo on here? Just a report. Here's your echo report.
It's a pretty good EF. No wall motion.
So the only pathology is a little LVH. And we always, when we do the echo, we also throw in whatever we think might be important at the time. So if somebody's having some chest pain, we wonder if they have gallstones, we have them come in NPO and we look at the gallbladder at the same time. If they have, if they don't have gallstones, but they might have gallbladder dysfunction, we'll look at the gallbladder and then give them a little drink of milk or something and take another look at it and see if it's squeezed down. We'll look at the carotids and look for carotid plaque. And she had bilateral calcified carotid plaque, no non-calcified plaque, no obstruction, normal carotid hemodynamics. What would you like to do next, Pooh?
I mean, CAD is always a possibility. She has risk factors. She has calcified carotid. So some kind of ischemic evaluation. Next, we have a variety of SPECT I hate in women. That's an option. Other than that, we could do a CT right bundle.
Pooh, what is cardio-oncology?
Cardio-oncology would be people who've had either are having or have had cancer treatment, any anthracyclines, anything. We follow them over periodically to kind of monitor if they've had any side effects from their treatment, because survival for oncology is increasing. So now we see more of side effects 5, 10, 20 years also later down the line, which we kind of follow up on.
So this might be a little bit early for left breast chest radiation. Plus the radiation they do pretty much today is basically coned down so that you avoid the heart as much as possible and try to just treat the area. And so that's unlikely that she would get changes in her coronaries with fibrosis or early atherosclerosis from the radiation. But what we see usually is the most anterior vessels, which are left anterior descending and main left. So let's see what test would you like to do next?
Some kind of stress test.
Okay, so we go for anatomy nowadays. So we have choices of anatomy and function, and so we go for anatomy. If you got normal anatomy, then we don't worry about function. And so anatomy is much more definitive. You're going to get used to seeing anatomy as our first choice because so many people don't have anything wrong or have just a little calcium, and so it's very easy to do this test, and we've got it priced right. For insurance companies don't usually pay for that without symptoms, even though you have risk factors. And so we have an out-of-pocket price for $199. That doesn't include the overread or the physician's read, but it's the technical charge. And that's pretty reasonable. When it's all done and said, it's about the price of a tire, so not a bad deal. And so let's take a look at her coronaries. And of course, we can give you a quick overview, and we don't want to be too specific for the coronaries right away because, you know, after all, we'd like to see the heart and we'd like to see the chest. We're always looking for breast tumors in these patients. And looks like there's a nodule there. See the nodule?
Mm-hmm. Oh, yeah, that's it.
So you don't ever miss anything like that. So we're always looking for stuff. And we also you can track the blood vessels, and you can actually track the internal mammary artery as it gives off mammary branches. And you can track those branches. You can pick a branch and the computer will follow it for you. And you can see where it goes and look for a tumor blush. So there's lots of things you can do with that part. And so looking at the heart overall doesn't look very LVH-y here. We can measure and see what kind of thickness we have. But it doesn't look very LVH-y on this particular image that we're looking at. I was looking at the junction of the cord with the papillary muscle head and measuring there, and it didn't meet the criteria for LVH. Right ventricle, right atrium. We don't see any pathology over there. Somebody with right bundle branch block, and Pooh suggested we look for right-sided pathology, and it looks like it's pretty clean over there. I don't see any right-sided pathology. We can also look at the lungs, and we have some good images of the lungs if we want to put the pictures on the lung mode. And with that, we can tell you if there's any lung problem. And we have various ways of studying the lungs with lung CT. And so here we are with lung CT up here. And you can see there's no emphysema, no COPD. I don't see any blebs, no flattening of the diaphragms. And so it looks like right-sided pathology is pretty much ruled out. So, and then we can look for pulmonary emboli. So we're going back to the arteries. And so we've got the full range of options with our viewing system. Then we're back on the heart, and we've had a nice jaunt over to the chest. And now we can look at the heart arteries. So let's take a look at right coronary, has a little rock in it. And let's analyze that a little bit in terms of our plaque analysis, like we did last time, and see what that plaque has to tell us. This is called reading the plaque. And so come down the left anterior descending, which is anterior. Here's a big diagonal vessel, right coronary over here. Circumflex is going around that way in the AV groove. And so we can just come right down here, and we come to this big rock. And you can see that even though there's blooming artifact, and this looks much bigger than it actually is because of the CT physics, we still see an excellent channel going through there, which is this green symbolizing the blood flow contrast through the channel. And so this obviously is not a severe lesion. Okay, one, it's not as big as it appears to be because of blooming artifact, and two, even with that, we still have a nice channel coming through there. And so let's go to something else and see if we got anything in the right to note. And so we'll go to the right coronary. And we can go down here and take a look at the right. And there's the posterior descending, and there's the posterior lateral branch. We can track out here. We got a little track marker here that we can use for drawing a line and getting it to track. So we're coming down the posterior descending in the interventricular inferior sulcus, and then posterior laterals over here. And so that's about as distal as you can get. So that looks pretty good. Let's go to the circumflex and see what that looks like. We'll turn over here to the circ, and it kind of jumped around over here so we're going to have to make a little line here and go back this way. I'll go back that way, up the circ, and try to track this a little bit. And then we can, if we don't like the way this is tracking, and we can also look, while we're here, we can look at the diagonal. Sometimes people have two LADs, and they parallel one another, and both give off septal perforators. And the double LAD would come down this way, but we don't have a double LAD. So let's go back over to get a better idea about the circumflex, since we didn't see that very well. So we're going to come off of here, off of showing vessels, and move over here with our workstation. And now we can come up here and find, aha, we find that the circumflex is coming off over here by the right coronary. So that's why we couldn't find it. So here's the circumflex origin right next to the right coronary, out of the right coronary sinus. And so normally, let's go look at the main left. Here's the main left, and it's not really a main left anymore because it's just an LAD. And there's the LAD, and there's our area of calcification. And normally the circumflex would have an origin right in here off the main left, and then we'd see it coming around. But we don't see it. Here it is. It's back here. And if we follow that back, following it back, following it back, following it back, we see that it has an anomalous origin. And it comes off of the sinus of Valsalva with actually a separate origin. It's not coming off the right. It has a separate origin. And it's coming posteriorly. This is anterior. That's posterior. And it's turning around the left atrium and around the aorta, and then coming back here and getting into the atrioventricular sulcus, and then coming back this way, and it looks totally normal. I don't see any evidence of any blockage, and so that takes care of the circ. And the circ was a little surprised. This coronary anomaly is not pathological. It's probably the most common coronary anomaly, and that is the origin of the circ off the right cusp, but it's not pathological, so you don't have to worry about that, factoring that. And so overall, this looks pretty good for this patient, so we can say that we don't think her right bundle branch block is related to right ventricular pathology, and we don't think it's related to coronary artery disease. So in summary, we had mild, moderate stenosis of the left anterior descending, less than 50% for sure, some remodeling, which means it's either negative remodeling, which means it's smaller than it was before, or positive remodeling, meaning it's bigger than it was before. The first diagonal has a little luminal irregularity, the anomalous circumflex coming off the not right coronary artery, but the right coronary sinus of Valsalva, or the right cusp. The absence of non-calcified plaque is, we showed you last time what vulnerable plaque looks like and what non-calcified plaque looks like and how dangerous that can be. So having a focal one coronary calcification reduces the risk of having a heart attack to less than 1% per year. It doesn't entirely minimize it. It's not the same as having no coronary disease, because no coronary disease gives you a 15-year warranty. So having a little focal calcifications gives you a risk of less than 1%. And a calcification can erode through the endothelium and actually cause a thrombus, cause a clot, and cause a lesion, and cause acute coronary occlusion. So calcification has some risk to it, but it's low risk, and it's only like 8 or 9% of all MIs are from a calcified plaque eroding through. And that's usually in someone like this lady, who's a lady that middle-aged female, and that's the common one that erodes through. The overread by the radiology revealed a nodule in the left breast, but we're not surprised about that because we saw that too, because we're all trained to look at everything, not just to look at the heart. So, in the meanwhile, patient comes every 6 months for follow-up of her high blood pressure and to see if her right bundle means anything, which we don't think it does, and is doing fine. And we see her on a routine 6-month follow-up visit, which she seems to come on January the 13th, a year ago, January the 13th this year. So here she is again. And she says she had a recent episode of chest pain in November while lying down in the afternoon, lasted a few minutes, went away. It was a burning, left-sided, and that's all. But she was pretty impressed about that, enough to tell us about it. We didn't have to prompt her. And she also just hasn't felt up to par. She's been somewhat fatigued and just hasn't felt good. She's been depressed. She's got a lot of stress in her life. But when we talk to our patients, who doesn't have a lot of stress in their life? And she's tired, but who's not tired either? And so basically that's all we know about her. But You know, here she is, no new complaints, increase in stress, worrying about her husband's health, whom we see too. She ran out of her medications, not like her. Being a nursing assistant, you'd think she'd be in tune. But she was so busy, she ran out of her medications for 2 or 3 weeks. Not any chest pain except for that one little episode in November. And so here she is. Do we do anything further in this lady, Pooh?
I mean, restart her meds for sure.
That's
Fill
a
them
good
out.
idea.
And then, I mean, we've already do have an anatomic test, so no point. We know her anatomy. Her risk of having, as you said, anything bad would be less than 1% a year, just by going with that. But I mean, we still can't explain that low voltage. We haven't pinpointed yet, but it looks like there's something causing her symptoms.
So I'm on a Medicare audit committee, and one of the audit things they're always looking at are EKGs. They say, why did you do this EKG? And I'm a cardiologist. What do you think? I mean, somebody's going to come in my office and not get an EKG? And here's a lady who had an episode of some kind of chest pain back in November, and so I did an EKG. You know, Medicare probably wouldn't like that. They don't like all these EKGs. What is it, like $5 tests? What's the matter with them? But anyway, we have to always justify our EKGs, and so hopefully this one was justifiable. And so physical examination, there was really nothing. And here's her EKG. Here's her EKG, Pooh. Take a look at this and tell me what you think about her right bundle now.
Wow, now it's a strain pattern, and those, I don't like those deep T-wave inversions. Although they can happen with right bundle, but they're too deep. Like sometimes it's even looking like Wellens in some leads. But yeah, right bundle with strain pattern, that first degree AV blocks still present, that the T-wave inversions are what really stick out. AVR looks like the ST segment's a little bit up. Well, I can't see it too clearly.
So Pooh is all over this one, and so man, these are deep T-wave inversions. These are really scary for us cardiologists, and so sure, you get T-wave inversions in V1, V2, and V3. Sometimes a transition zone somewhere around V3 or V4 in right bundle branch block, but and it's concordant with the QRS. But this is totally different. These are like deep valleys all over the place, and so this certainly looks terrible. So what do we do now, Pooh? This looks awful.
It's almost looking like a STEMI equivalent. Like right off the bat, we can, I mean, either it's subarachnoid or it's like deep T-wave L-inside, prox LAD, AVR is up. So if we want to, and she's complained of chest pain, if she's still having chest pain, a CAT won't be unreasonable. I mean, I know most people here would do it.
Yeah, so this was one episode of chest pain 3 months ago. And so...
Yeah, but how do we explain the EKG? Another, we could do a bedside echo, see if there's any regional wall motion abnormality. And I guess we can justify that another echo.
You would want an echo, right?
Mm-hmm.
You say the magic word echo. And so let's get an echo. So this is our echo, and maybe you can tell us about it as we navigate through here. Try to give you as many images as we can. Looks like we have one series. Here we go. So we got all kinds of echoes here. So try to get you some more motion. Axis for you, and I can move it through faster, perhaps. Contractility in the short axis. Takes a minute to get all these images loaded, but here's a nice one. Let's get this one to move a little bit. Oh, there we go. We're getting good motion, sort of. So Pooh, comment on the motion of this sort of almost four-chamber view, almost four-chamber. Looks like an echo.
Sorry, go ahead. What were you saying?
Go ahead.
So basically, both short axis and this apical core showing that from mid-septum and mid-lateral wall to apex is almost dyskinetic, so only the basal portions coming in. Basal portion seems to be coming in pretty good, but mid to apex is dyskinetic, both on short axis and this.
So the apex is out.
Right.
So any thoughts now on this information after this great revelation?
I mean, EKG showed changes in the anterior leads. Apex is dyskinetic. LAD occlusions, definitely a possibility. I mean, down the line we can say, oh, a differential we can expand, but first we have to rule out ischemia. Unlike this, coronary should be clean, and then after that maybe we can think of Takasuba or something else, but we definitely need to rule out ischemia.
Any comments about the strain imaging on this patient?
So strains showing, let's see, strain in the basal portion is pretty good, and apex is again in positive numbers. So anytime it's in positive means that's out or dyskinetic. So basal strain is good, and then as we come more towards mid to apex, apex is blue, so that's gone.
So we're looking at the bullseye, and we're seeing the apex, we're seeing the anterior wall, and all this area, the same area we described as having abnormal wall motion in the description from the strain, which is a mechanical measurement of the left ventricle. It's not the same as the ejection fraction. What we're seeing here is abnormal mechanics. That is shortening of fibers within the wall is abnormal. It's markedly abnormal, and it's going the wrong direction. Strain frequently precedes LV wall motion abnormalities. Decrease in strain will precede ejection fraction decline. And frequently, when the wall starts improving, the strain gets better before the wall motion gets better. So strain can be very useful for us in patients in our cardio-oncology field for trying to predict who on anthracyclines or on tocilizumab, who is actually getting some damage to their heart early, so that we can start them on a beta blocker or an ACE before they get ejection fraction deterioration. So now what do you think? What would be your diagnosis at this point, if you want to be so bold?
I mean, basal hyperkinesis, apical dyskinesis, Takasuba is in the differential, but given that EKG, and we can't say for sure unless we do a lot of obstructive CAD, unless we do a CAT, that's more of by exclusion, right? We say, okay, coronaries are clean, and then we come to that differential.
So given the disease that we saw in her coronary CTA, just that one little hunk of calcium.
Yeah, it's very less likely, I know. I mean, less than 1%, as you said.
We're saying it's very unlikely that that calcific plaque eroded through the endothelium. Although it happens, and it's in this kind of patient that it happens, females middle age or older, and
she was out of her med.
On the other hand, what other factors would you consider? Coronary spasm, coronary embolus, what else would you think about?
Spasm, embolism, aneurysm, Takotsubo, she's been under a lot of stress.
And so what do you do next?
I mean, we could do, she's asymptomatic right now, we could do MRI, see if there's a scar tissue, if something's already scarred, if it's viable, dead.
So basically, I felt that the choices we had here were to one, rule out that she ruptured that plaque, which is unlikely, very unlikely, less than 8%. To rule that out, and also then to, if that rules out, and if she doesn't have coronary disease, to consider something called transient apical ballooning, or Takotsubo syndrome. And so, being a mystery game that we're playing, that would be a mystery diagnosis, and that's a pretty good one. So let's look at the coronaries and see if we see anything significant in, I guess it's been 2 or 3 years since her coronary CTA. And so we're looking at which vessel here, Pooh?
LAD, the diag, given the EKG and the echo finding.
Looks pretty good. It's not a very big LAD, but it wasn't before. Doesn't hook the apex. So it's unlikely that this would be a coronary thing. Even from what we already knew, it's unlikely because the LAD didn't hook the apex and doesn't supply the apical inferior wall. That would have to be a big LAD. And so we know from the coronary CTI that it wasn't a big LAD. It didn't hook the apex. It was really a big diagonal and just a little LAD that's septal perforator. Runs down to the apex but doesn't go into the inferior interventricular sulcus and does not go up and supply a third of the apex like sometimes LADs do and meet up with the posterior descending that's coming off the right from the other direction. So it doesn't do that. So it's unlikely that this distribution of left ventricular dysfunction correlates with the coronary anatomy. There is no correlation. As you know, this is not a main left coronary because the patient has an abnormal circumflex that comes off the right sinus of Valsalva. So this is the right coronary artery. What do you think about that?
I mean, there's some 20-30% disease approximate, but or maybe 40, but nothing that looks bad enough to be causing EKG changes.
I think we have an LV gram and a root. And would you like to describe our left ventricular gram if we can find it? There it is. Pooh, what do you think about the contractility there?
I don't see it. There's nothing showing up on my screen.
We'll get it up for you. That's okay. It's we're trying to get it up. So we can't really show you that, but the left ventriculogram matches the echocardiogram, and again there's inferior apical. So they also did an aortic root that I can't seem to show you, and the aortic root shows the anomalous circumflex, and I guess they weren't prepared. The angiographer wasn't prepared for the anomalous circumflex from the CT data, and so did not selectively engage that. But since we're looking at the anterior wall, that wouldn't be important. So let's go on and talk about where we are now. So here we are, Pooh. We got medical therapy. We got CMR. We also have echo that I didn't put up there, but we've got echo as well.
So medical therapy, I mean, we'll restart her meds, aspirin, statin, beta blockers, whatever she was on at home. MRI to see for scar tissue or versus. Usually if it's Takotsubo, it should improve, so we'll treat her and get her back in like 3 months or so, repeat the echo, see if it's improved or not.
So with Takotsubo, there shouldn't be any scar tissue. So we wouldn't see
should not be.
That would be pretty characteristic, no scar. There'd be a lot of edema on the T2 weighted, but on the late gadolinium enhancement, it would be negative. But we do have an echo. What do you think the echo is going to look like? This is done a week later.
A week later, while she's been started on treatment.
Think it's going to be back to normal or still be the same?
It should have improved some if she started taking her meds, if her stress levels decreased. It's a slow course over which it improves. Every person is different. But I'm hoping it would have improved.
Okay, we'll get our echo up here and show it to you. Okay, here we go with the echo. Whoa, look at that. Look at that contractility of the anterior apical inferior. So, Pooh, what do you think?
Yeah, it's normalized. It's coming in pretty good. So that's more in favor of Takotsubo. It was transient, didn't fit any coronary anatomy correlation, the wall motion abnormality. It's coming in really good.
We will in the future do a CMR just to make sure that there's no subendocardial scar and that's eliminated, because you can have normal LV contractility with subendocardial scar like we showed on the gentleman last week, and so that can happen, and so we want to make sure that there's nothing going, no subendocardial scar residual. And that brings us to Dr. Alan Chen, who's going to be talking about Takotsubo syndrome. He's going to tell us all about stress-induced cardiomyopathy, and we're hoping he tells us what the cause of this is, because it certainly is strange. Hang on for Dr. Alan Chen.
All right, good morning, everybody. I'm going to give you a brief overview of stress-induced cardiomyopathy, or also commonly known as Takotsubo's cardiomyopathy. Some of the other names that you may have heard of include apical ballooning syndrome, broken heart syndrome, and it's defined by a transient systolic dysfunction of the mid and or apical segments of the left ventricle, and this is in the absence of obstructive coronary artery disease that could have caused these wall motion abnormalities. And most oftenly it's associated with some sort of intense stress or emotional trigger. The reason it's called Takotsubo cardiomyopathy is because the word Takotsubo is a Japanese term for octopus trap, and it seems to resemble that kind of shape. It's not that common of a disease. In one study, it occurred in about 2% of patients who presented with suspected acute coronary syndrome, and for some reason it occurs more commonly in women than men, and often affects postmenopausal women. Actually, it's not exactly clear what causes Takotsubo cardiomyopathy? There's many theories. Some possible mechanisms include: one, because of the intense emotional stress and stimulus, maybe a surge of catecholamines causes microvascular spasm or dysfunction of the coronary vessels. Other theories include possibly the patient actually did have a myocardial infarction, but the clot was self-limited or dissolved and was considered an aborted myocardial infarction. And other theories include direct toxicity of the myocardial tissue from excess catecholamines. And this is thought of because some studies have noticed that in patients with Takotsubo, they have higher plasma catecholamines than those who present with just true myocardial infarction. And if you look at the histological tissue of patients with Takotsubo cardiomyopathy, there are signs sometimes of direct catecholamine toxicity. And once the Takotsubo cardiomyopathy resolves, the signs of toxicity and pathology are resolved as well. And when you go to the basic science level, why does Takotsubo cardiomyopathy occur? Why does it occur in this distribution where you have more mid and apical involvement of the ventricle? Well, in mouse models, I've found that you have higher densities of beta-adrenergic receptors at the apex, and when you have high epinephrine levels, such as in a situation of intense stress, those actually become negatively ionotropic, and that may explain some of the wall motion distribution abnormalities. So how do these patients present? So one, commonly they have recent physical or emotional stress, like we mentioned, but it's really similar to an acute MI, and oftenly it mimics acute coronary syndrome, where it's difficult to be able to distinguish just based on the clinical presentation. So they can have similarly chest pain, shortness of breath, diaphoresis, and they can even be very sick and develop shock. On exam, there's nothing specific for Takotsubo cardiomyopathy, but in certain situations, such as when you have in Takotsubo, when you have a hypokinesis of the mid-ventricle and apex, you often have compensatory basal hyperkinesis. In that case, sometimes you can develop issues with systolic anterior motion of the mitral valve and SAM, which can lead to LVOT obstruction and then a murmur that is heard in that situation. And the same pathophysiology, once you have systolic anterior motion of the mitral valve, you can develop mitral regurgitation. What about EKG? Again, there's not really something pathognomonic for Takotsubo cardiomyopathy, but you can see all kinds of things: ST elevation, deep T-wave inversion diffusely. It has been noted that you have significantly prolonged QT interval prolongation in Takotsubo, greater than 500, which you do see QT prolongation in ischemia, but usually not more than 500. And you can also see abnormal Q waves, and in some cases the EKG can be totally normal. It's also another, so also you can see it can be difficult to distinguish between myocardial infarction because the troponin may be elevated, although usually just mildly elevated, and BNP may be elevated too. We mentioned on echo you have wall motion abnormalities. The average EF is usually between 20 and 49%, and it's, again, it will affect the mid and apical segments of the left ventricle. So what about some advanced imaging techniques for evaluating Takotsubo cardiomyopathy? Well, if you use CMR or MRI, it'll give you excellent visualization of both the ventricles. And it's also useful because you can rule out other potential causes of these unique wall motion abnormalities, such as aborted MI and myocarditis. So for example, in the MRI, we can look at late gadolinium enhancement, which represents scar. And this is usually absent in Takotsubo cardiomyopathy, compared to if the patient had an MI, it would be subendocardial involvement, and in myocarditis, it's usually patchy. Also, with MRI, we can look at myocardial edema, and that's commonly seen in Takotsubo cardiomyopathy. And we can also look at the pattern, which in an MI, which would correspond more with the vascular territory and myocarditis again, maybe mid-myocardial or patchy. What about CT in the setting of Takotsubo cardiomyopathy? So there's limited experience out there in the literature using CT, but it may be useful because one, when you scan the chest, we can rule out other etiologies of a patient presenting with chest pain or shortness of breath. And we can consider cardiac CT being reasonable as an alternative to coronary angiography for maybe low risk, low to intermediate risk patients who are, especially ones that are stable, to rule out coronary artery disease. But really the gold standard and the way to really clinch the diagnosis is to rule out coronary artery disease as a cause of these wall motion abnormalities, or coronary angiography showing either normal blood vessels or some coronary artery disease, but out of proportion to the amount of wall motion abnormalities. So coronary artery disease that could not have caused this kind of systolic dysfunction. And then when you do your catheterization, you can also do left ventriculography to look for mid-wall hypokinesis or apical ballooning. Actually, there's also atypical variants too. So there's one type that's only involving the mid-ventricle. There's one that only involves the base, so that's kind of a reverse Takotsubo. There's atypical variants that are just focal. And also, one study using MRI showed that actually in about a third of the patients, the right ventricle is also involved in Takotsubo cardiomyopathy. One of the criteria that's commonly referred to and referenced is the Mayo criteria for stress-induced cardiomyopathy. So you must have, so everyone thinks Takotsubo cardiomyopathy is apical ballooning, but really what you must have is mid-ventricular involvement. You don't even have to have apical involvement. You must have mid-ventricular involvement plus minus apical involvement. Number two, you must have ruled out obstructive coronary artery disease as a cause of this issue. You should have some evidence of cardiac injury with EKG changes or biomarker elevation. And you should have ruled out another cause of the same presentation, such as pheochromocytoma or myocarditis. How do you approach these patients? You cannot say, I just think from history and physical this is Takotsubo and then treat them differently. If the presentation is similar to ACS, this patient needs to be treated just like with standard of care practices until you've definitively ruled out obstructive coronary artery disease and have definitely confirmed this is Takotsubo. It's more of a diagnosis of exclusion. So similarly, if they're presenting with signs and symptoms of acute coronary syndrome and they have SC elevation on EKG, no matter even if you think this could be Takotsubo based on a recent emotional stress or the way the echo looks, same thing, go to the urgent cardiac catheterization, and if it's not ST elevation, then treat them as a non-ST elevation MI. Again, suspicion of a diagnosis of Takotsubo cardiomyopathy is not sufficient to withhold standard of care interventions. There's no control data to define the optimal medical therapy. Long-term management is largely supportive, and it's reasonable to treat these patients with a standard medications for left ventricular dysfunction. How do these patients do long-term? Pretty good, actually. Studies showed mortality rates in the hospital range from just 0 to 8%. And the unique thing about Takotsubo is with all these wall motion abnormalities, is the patient's left ventricular function usually recovers. And it usually takes between 1 to 4 weeks. You have to show that the patient's LV function has recovered in order to really confirm the diagnosis. And patients who are able to survive the event, they only have about a 2% per year risk of recurrence. So the key points for this are, one, Takotsubo cardiomyopathy is a transient systolic dysfunction characterized by mid and or apical wall motion abnormalities. The presentation is very similar to an acute myocardial infarction, but there is no coronary disease or obstructive coronary disease. We can use an integrated approach with multiple imaging modalities to help confirm the diagnosis. Just suspecting Takotsubo cardiomyopathy based on your clinical judgment alone is not enough to withhold standard initial interventions. And these patients do well and usually recover their LV function within 1 to 4 weeks. And that ends this portion.
Thank you, Dr. Chen. I think it's time to throw it open to questions. And so if anybody here has any questions, please question up. And I have a couple questions to start with for Dr. Chen. And one is that we have an imaging technique for imaging adrenergic sympathetic stimulation of the heart. There's an isotope that we can use in patients with congestive heart failure that is predictive of mortality. And so that was approved like last year or so. Would that be of any use? Has anybody used that in this disease to your knowledge?
Yeah, actually there's been some data out there using this nuclear technique to look at what imaging characteristics you see with Takotsubo, and either it's just standard nuclear techniques or using this sympathetic marker, as Dr. Harrison was talking about. But we don't know too much because there's not that much literature out there, but it's definitely an intriguing thought.
Okay, the other interesting thing is this is a patient with asymptomatic Takotsubo. So you can Google asymptomatic Takotsubo and you'll find that there are quite a few people. She just came in routinely for a follow-up visit and at her 6-month appointment, and we bumped into Takotsubo. Seems like that would be pretty uncommon, and you wonder about people having sudden death and basically having Takotsubo and undiagnosed, either pre-sudden death and undiagnosed on autopsy. And so that it's a cause of sudden death, so also could be a cause of ventricular fibrillation. We did basically presuppose that she had Takotsubo from her clinical findings, her history, no chest pain, the chest pain event she had in November, the fact that she had pretty good looking coronaries on CTA in 2013. So we did withhold conventional therapy. We didn't put her on aspirin. We didn't start her on heparin or Lovenox. We really didn't do much of anything but send her over there and get a cath and prove that's what we thought it was. And then she wound up on a beta blocker, I presume to prevent remodeling on an ACE. But basically, we don't even know if those are the drugs that are indicated because there's no randomized study. It just happens. But Takotsubo seems to be a lot more common than we ever thought it was. Seem to be seeing some places they see one every month. And there's a couple of registries. Dr. Paolo Angelini has put together a registry at the Texas Heart Institute, and we'll probably be joining that registry with this particular case because he'll be very interested. And we'll present this case to him on his coronary anomaly presentations that he has once a month from our network. It's usually the second Wednesday of the month at 5 o'clock that we present cases to Dr. Angelini that are usually adult congenital heart disease. She gets in the back door because she has a coronary anomaly. And so we'll talk about asymptomatic Takotsubo. So thank you very much for your attendance. We appreciate you coming. Anybody have any questions? We will call it quits. And, yes.
No, I'm okay. Thank you.
Okay, great. Thank you so much, Janet. Several Janets. We have 3 Janets. The Janets rule today. Kelly, Carinsa, Mary, Mindy, Pooja. Thanks, Pooja, for contributing to the questions and answers. Shannon, Sharon, Shirley, Teresa, and Whitney. See you next week. Bye-bye.
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 Thank you.
Bye-bye. Thank you.